Okay, good afternoon everybody, and thank you very much to the Global Health Academy for giving me a chance to come a relatively short distance compared to where I usually go for my work. Thank you very much indeed. And what I've chosen for my 15 minutes, and I know I'm going to be very steeply marked for timekeeping, is what I'd like to focus on is this issue of getting research into policy and practice. So the title I've used is a sort of play on words. And I'm going to talk about what we call the Stubborn MDG, the Millennium Development Goal number 5, which is about reducing maternal mortality. And I've called it stubborn for a particular reason. Maternal mortality, as you'll hear, I'll come on to say, in terms of still a global problem, so much so that in places like this picture taken from a hospital in West Africa, where I've worked collaboratively for many years, shows that it makes a lot of sense to put the mortuary and maternity and paediatrics next to each other for very practical reasons. So I'm going to talk about GRIPP, getting research into policy and practice, and I'm going to do that because I think it's a generic issue that affects us in global health research, and particularly as a way of perhaps weaving together some of the themes that have already cropped up this afternoon. So why do I call it the Stubborn MDG? This works. That's a stubborn, here we go, it's a stubborn keyboard as well. Yes, this is the latest data from the World Health Organization about describing the progress towards Millennium Development Goal number 5, which has the unenviable title of being called the most off target of the 8 MDGs. And what it shows here, I get this right, is the level of maternal mortality up to the left-hand margin and the period of time. And the goal was to have a 75% reduction in the period between 1990 and 2015. And what this shows is, although there indeed has been a non-trivial amount of progress, relative to the target, and we're only 3 years away, we are seriously off target. So this is why it has this title of being the most off-target MDG. Now, I call it stubborn because that would imply that we could have expected better. And that's where this issue comes in about the whole question of the role of evidence. And when I think about the phrase, the term to describe this conference today, do we really have the evidence? That is extremely dear to my heart, and also my work at DFID as well, where we're talking about whether we really have the evidence or not. So I call it stubborn because I think we might have reasonably have expected greater progress. Why do I say that? Well, we have evidence, we have political commitment, and we also have resources. So let's just run through some of those. This won't work that way, will it? Button confusion here. Political commitment, absolutely key. And I think the fact that it was made an MDG, maternal mortality was made the goal of MDG 5, pushed it way up the international agenda. And of course now, and very recently, we see Ban Ki-moon launching a new global strategy for women's and children's health, launched in 2010, again to rally support for doing something about these preventable deaths in pregnancy and childbirth, maternal deaths, and using what we often use as a phrase, we know what works. We know what works. Very high level political commitment internationally, nationally, and at local levels. And it's often said we know what works. Now, there's no one type of evidence. There's no one truth. There are lots of different types of evidence. And so when it's said we know what works, we're sort of making some assumptions about what we're using by evidence. But already, some of the previous speakers have already alluded to history. So let me use history. This is the success story here in the United Kingdom of the reduction of maternal mortality over quite a long period of time. But there was this very dramatic fall in 15 years between 1935 and 1950. Before that, this level of maternal mortality, the chances of dying in pregnancy and childbirth, were about the same as what we see in Malawi today. Until about 1935. And the quote up here indicates one of the triggers, there were many of them, political commitment locally in the United Kingdom saying enough is enough. And then we had this dramatic fall. Now, history is a funny sort of evidence in some ways, and it's always hard because it's not a randomized controlled trial and we can't control all the confounders to know quite what worked. But there clearly were a number of factors, and in fact some of the speakers have mentioned some of those already. There were things like improvements in the service, the system, particularly in the lead up to war and during the war years. Interestingly, arranging obstetric flying squads, improving the blood banks, those sorts of activities to improve a functioning health system. And that's very, very important. Were put in place very, very quickly. There were also things like improvements in the training of workers. The quality of care improved. And there were broader factors as well. Changes in the status of women, changes in education, to pick up the theme from earlier. There were many things going on. But of course, given what we're saying about the role of science and the role of evidence, were there technologies, were there things happening more on the technological front? And I think the answer to that is certainly yes. There were many drug discoveries during this time, delivered through very large needles and very scary hairdos, as you can see, just to really scare you. But of course there was penicillin, before that, sulfonamides. Penicillin mass reproduced during this period, and also ergometrin to help reduce risks around hemorrhage. The penicillin was obviously to essentially eliminate deaths from sepsis. So there was drug discovery. But the point is, there was no magic bullet. I'm sorry to counter that. I'm not talking about education here. There was no single magic bullet that explains that 80% decline in 15 years in the United Kingdom. That's the historical evidence. And elsewhere, where we've seen falls in maternal mortality, there is no single intervention alone that can prevent women dying at scale, equitably delivered across all settings. So there is no magic bullet. But we do, in fact, know a lot. So if we come back right up to date, we know, this is the latest publication from WHO and the partnership produced in 2011, there are about 56 essential interventions that are relevant for saving mothers and newborns and children. 56 interventions. And again, this phrase saying we know what to do. And also these 3 key strategic approaches. So prevention of unintended pregnancy through family planning, prevention and management of mild complications, skilled care, particularly at delivery, and the prevention of death by rapid and effective management of life-threatening complications. So, do we really have the evidence? Well, at one level, the answer is yes, we do. We do. But we have a particular type of evidence. And the question then is, do we have all the evidence that we need? Because the reality is that maternal mortality has remained extremely stubborn. I was just trying to calculate about maybe 500 maternal deaths in the world during the course of this meeting this afternoon, about 1,000 a day, deaths during pregnancy and childbirth. 287,000. Remember, we have the evidence to prevent maternal deaths at one level. The global distribution shows you this inequity of deaths occur, with virtually none of them happening. We have about 155 maternal deaths over a 3-year interval in this country. Here we are seeing 99.2% of the global total lies in the developing world. And it has, again, the accolade of being the largest indicator of gap between the rich and the poor countries in terms of a public health indicator. Somebody was asking me, I think it was asking me earlier, about the risk of maternal death in somewhere like Sweden. 1 in 30,000. 30,000 women who enter the reproductive period, 1 of those 30,000 are likely to die of pregnancy-related causes. In Chad, 1 in 7. 1 in 7. It's a huge difference in the modern day. And to crown it all, it's estimated that 88 to 98% are preventable. So, what is it? Why is it that we have a problem that has high political commitment, resources being put into it, and an evidence base of sort? Why has it remained so stubborn? And I'm sure all of you that are involved in global health will know that at the moment there's a lot of soul searching going on about the post-2015 agenda. What are we going to do after 2015? What's that agenda going to be looking like? And taking stock of performance and the bottlenecks. And so in the maternal health community, both researchers and the broader community of individuals concerned with preventing maternal mortality, there's a lot of soul searching going on why might this be the case. Why is it that we have evidence that is not being taken up into policy and practice and programs? Why? Why do we have that? And of course it takes us into the wonderful world of policy making. And this is where I like to, I'm sure everybody knows the saying, there are 2 things never to watch being made. One is haggis, or sausages, and the other is policy. And one of my other roles is working with DFID, and I'm certainly not saying it's a sausage making factory, but policy making is a very interesting process. It's a process, it's never an event. But we of course know that what goes into policy and programs is not just evidence. The reality is there are values, judgments, and there are resources as well. So it's certainly not the case that it's just evidence that gets taken up to drive what gets put into practice, what goes into policies. But I do think there is a moment now for those of us who've been working on this subject to reflect back on the question of what has happened to the research that we've generated, the evidence that we've undertaken. Are we achieving GRIPP? Are we getting it into research, our research into policy and practice? And what I want to emphasise is that this is not an end process. Some people think GRIPP is what you do at the end of your research cycle. And what has struck me from my work, particularly around maternal mortality reduction, is it's a process. And one of the reasons why we don't have uptake is perhaps we've not asked the right question. The right question for whom is the big question as well. Are we generating fit for purpose evidence? There's no one type of evidence, and it has different roles depending on different needs and for different purposes. And are we going this extra mile to communicate evidence and disseminate it? It's a process. And I think it is our responsibility as we think, I'm not suggesting for 1 minute it's the lack of uptake, it's the research community's fault, inverted commas, that maternal mortality has remained so stubborn. But nevertheless, we should take responsibility for our part in terms of thinking about, can we do more to improve GRIPP? What this involves is multidisciplinary work, working in partnerships. It involves working particularly with partners in country and really working to understand what they perceive as the bottlenecks. And this comes to this project that I have been the leader of since 2002 called IMPACT. IMPACT is trying to have an impact, hence the name, on maternal mortality and newborn mortality. It started in 2002 with a multi-million-dollar award from the Gates Foundation, DFID, and the US government. And what it's trying to do is improve the evidence base for decision makers. So it's a particular type of evidence that we're seeking in terms of doing complex evaluations in country, working with partners on the ground, locally, nationally, and globally. And in the first few years of the project, we ended up focusing very much on working in 7 different countries, and since then we've gone on to work in other areas. One of the particular focuses of our work is around quality of care. Probably one of the biggest bottlenecks in reducing maternal mortality. So this process of, if your GRIPP is not just this piece at the end, when you've got your stuff, what do you do with it? You have to also start in terms of thinking about, are we addressing the right question? Are we going about it in the right way? And then are we communicating effectively to partners on the ground? And we've learned many lessons in the 10 years we've been doing IMPACT. And although attribution of impact or an effect in terms of policy and practice is a very hard thing to do, attribute with certainty, we have a pretty good audit trail of where we've made a difference locally, for example in Indonesia, nationally in India and Burkina Faso, for example, and an influence on the global strategy for women's and children's health. And our lessons are, involve the decision makers on the ground from the outset. Do not go along, and we have this lovely story of a decision maker being asked, why didn't you use my evidence? And the decision maker turned around and says, but you answered a question I didn't ask. Please start by taking the perspective of those you think you are generating evidence for, and maintain continuity with those decision makers. Multiple pathways to GRIPP, strategic alliances. It's not those of us sitting in Aberdeen, Edinburgh, or anywhere else in the global north. It's who we work with on the ground. Who we work with on the ground. Strategic alliances. Capitalise on personal contacts and trust. You have to use those connections. We're human. Endeavour to provide timely finding, and that is a really hard thing. One of the problems is that policymakers move very quickly, and policymaking can move very quickly as well. Communicate effectively and repeatedly. I know I've got 1 more minute to go. So lots of challenges across the 10 years in which we've been working to help with others, not alone, working with others, collaboratively reduce maternal mortality. The landscape has changed in terms of who the stakeholders are. Please don't think you're working to generate your evidence for one constituency. There are lots of different stakeholders now in the knowledge process, and you have to understand them and communicate with them differently. It sounds like it's become more complex, and at one level it has, but I would argue failing to realise who we're trying to reach is one of the problems. We haven't acknowledged there are multiple stakeholders. But also, my favourite slide is this one, is that you also learn a lot about the policymakers that you're working with. You have to really understand what drives them. they seem like, there we are over there, coming from Venus, they seem like they're from Mars in terms of their elevator opportunity to get your evidence over to them, what really drives them. But you really do need to invest in that understanding. So to bring us back to these questions at the very beginning. The landscape has changed, and I think the expectations of researchers, whether it's the REF or our funders, the expectations are changing. This has implications for our organisations and who we train and how we train. It has implications for partnership. It has implications for the funders as well. So the landscape and the expectations of us are changing. And there's this issue in this area of global health of the difference between evidence-based decision-making or advocating around evidence and what some people will call over-advocacy. So, GRIPP, the question is, how can we do better? And I think maternal mortality is a particular example where it's good to examine those questions because there is an evidence base. I think there are major issues about the type of evidence, which we can perhaps come back to in the discussion. But I hope everybody here who's interested in global health, when you undertake research, you think about these sorts of questions at the very beginning. Thank you very much.